Hi, my name is Eun Park, and for this final project, I decided to take a look at the Patient Protection and Affordable Care Act, also known as Obamacare, and the way that it impacts racial and ethnic disparities in mental health. The U.S. Department of Health and Human Services defined health disparities as specific types of health differences that are closely linked with socioeconomic and/or environmental disadvantages. Race and ethnicity have been found to be some of the major determining factors for receiving high-quality health care. It's just one factor among a couple of others, which include socioeconomic status, insurance, or disease, which all play lesser roles. So other factors such as implicit provider bias, access to health care, social determinants, and biological factors contribute to these racial and ethnic health disparities. And although there have been efforts to reduce these disparities in the past, health disparities in the United States have been particularly resistant to intervention. Research has found that underrepresented minority populations are disproportionately burdened by chronic disease, shortened life expectancy, infant mortality, and other negative health indicators. In addition, these populations also typically have insufficient medical insurance coverage. The Patient Protection and Affordable Care Act, or the PPACA or ACA, was a healthcare reform act signed by President Obama in 2010. It was created with specific provisions that were aimed at eliminating disparities by improving healthcare access and quality. Some of the major provisions include guaranteed issue, which is a clause that makes it so that insurers can't deny you coverage based on pre-existing conditions. Policy minimum standards, called essential health benefits, were established, and it also increased the age that children can be covered under their parents' policy until 26. The individual mandate made it so that purchasing insurance was mandatory unless they were exempt or they paid a non-compliance penalty fee. State and federal exchanges were created to purchase insurance policies if they were not provided by your employer or government. Low-income subsidies became available to those that were purchasing insurance through the marketplace who had an income of less than 400% of the federal poverty level. They created Medicaid expansions. Some states were able to opt in or out because the Supreme Court ruled that they couldn't be mandated, and there were also Medicare pay reforms. To discuss disparities in mental health care, we need to understand that they're basically just extensions of the racial and ethnic inequalities that exist in general healthcare. The American Psychological Association published that Black Americans, Latinos, Native Americans, and Asian Americans are overrepresented in populations that are particularly at risk for mental health disorders. Additionally, minority individuals may experience symptoms that are undiagnosed, misdiagnosed for cultural, linguistic, or historical reasons. A number of evidence has been collected to support this statement. And to address this topic any further, we need to understand how the mental health care system works. It begins in the general healthcare system because most policies require a referral from a primary care physician in order to see any type of specialist. Without that referral, the insurance company may deny your claim. Mental health care providers, just like other medical providers, can be in or out of an insurance company's network, so the cost is going to vary according to the physician, service, and the network status. Individuals of minority and racial ethnic populations are more limited in access to mental health care, and these mental health care disparities, just like other racial and ethnic health disparities, exist because of the problems that they encounter at every level of healthcare. Following my research, I decided to ask the question, did the implementation of the Patient Protection and Affordable Care Act behave as an effective method of intervention in reducing the racial and ethnic disparities that exists in the United States mental health care system? I began my research by looking for background information, which was found on the internet through the use of search engines. Information pertaining to the history and state of healthcare disparities and the Patient Protection and Affordable Care Act were collected from credible sources. Further research was conducted by using a variety of journal databases. Articles related to general healthcare and mental health care disparities were collected. These articles included studies and research that ranged from before to after PPACA implementation. Following the accumulation of applicable articles, an analysis was conducted to study the efficacy of the PPACA in reducing racial and ethnic disparities in mental health care. Prior to the implementation of the ACA, more than 50% of the uninsured population in the United States was comprised of racial and ethnic minority groups. Further research found that with the passage of the ACA, larger proportions of Black and Hispanic patients would be newly eligible for Medicaid or Marketplace coverage with high subsidies compared to white patients. Larger percentages of Black Americans and Hispanics were targeted by Medicaid expansions. So on paper, it seems like it could definitely help reduce disparities, but real-life factors have affected the anticipated outcome. For example, around 3 out of 5 Black Americans targeted by the Medicaid expansions actually lived in non-expansion states, severely affecting their access to the same health care policies and care that other populations in Medicaid expansion states had access to. Following the implementation of the ACA, studies were conducted to determine the results of how the Act truly affected the minority populations. This particular study analyzed the rate of visits and payment types for primary care visits at community health centers across the country. They found that Medicaid expansion contributed to decreases in uninsured CHC visit rates for Hispanic, non-Hispanic white, and non-Hispanic Black patients. There were improvements across the board, but disparities definitely remained. For example, Hispanic patients remained the highest group in uninsured visit rates, and the decline in uninsured visits was significantly less for this group. Research was also conducted focusing on Medicaid expansion. Medicaid expansion was left up to the states, so 27 states and the District of Columbia decided to expand, leaving up to 4 million low-income adults without health insurance in the non-expansion states. The states that chose not to expand Medicaid actually had the highest rates of uninsured and poverty rates across the country. Some examples of these states are Florida and Texas. Minority, racial, and ethnic groups are disproportionately represented in these numbers, leaving many without insurance. This differential access to health insurance will continue to impede progress towards eliminating disparities in health insurance coverage. Racial and ethnic groups living in non-expansion states will only continue to fall behind as the country moves forward with health reform. Another important finding is that racial and ethnic disparities exist across nearly every aspect of society, not just healthcare. Black and Hispanic individuals experience lower incomes at the same education levels, less wealth at equivalent income levels, and less purchasing power due to the higher costs of goods and services in the residential area environments where they are disproportionately located. This highlights the necessity to address racial and ethnic disparities through additional social, economic, and political means, not just limited to healthcare. Universal and targeted interventions are both going to be required to address the fundamental causes of disparities in health. Universal interventions are those that include the entire population, and targeted interventions are aimed at reducing the gaps for specific groups, like racial minorities. To conclude, I found that data suggests that the PPACA was successful in lowering rates of uninsured and increasing access to primary health care. Although there have been improvements across the board, significant disparities still exist and prevent members from racial and ethnic minority groups from receiving equitable health care. I think that it's appropriate to conclude that the PPACA was partially successful in improving coverage and access to primary care physicians, therefore improving coverage and access to mental health care. Further improvements on healthcare policies are bound to be made, and data and studies in the efficacy of the PPACA and reducing racial and ethnic disparities is going to be crucial in determining further political action.